Let's proceed now with the physical examination. There you go. Any questions from the group about the physical examination of this patient? Can you tell us, Dr. Hudson, what are the numbers that we're looking at here? You know, what are the significance of all these numbers, and what should we be looking at on our COVID patients?
Yeah, so what we've noticed initially is this was very early on, is that we were seeing marked inflammatory markers in these patients. Most notably, the ones that you'll kind of draw your eye to is the ferritin, CRP, and D-dimer. Pro-Cal is not specific for COVID infection. However, Pro-Cal is something that's commonly being monitored in order to rule in or out or provide some evidence for or against a bacterial co-infection. And so those are the main things that we're watching.
And how often are we requesting this laboratory in our ICU patients?
So usually in our ICU patients, we're drawing these labs daily. And so these labs are kind of giving us a general overall marker of inflammation and how inflammation is progressing. They're not incredibly specific yet for the outcomes that we can expect from patients. However, we're more determining our level of inflammation in that specific day.
Yeah, and just to add to that, Dr. Hudson, I think the primary inflammatory marker that has been associated with more severe illness is D-dimer specifically. And so this patient's D-dimer is what we would consider elevated as compared to normal limits as to what you would see in you and I or a patient of good health. So 1.5 is considered above normal. However, the most recent literature in terms of D-dimer, somewhere between 2 to 3 above that range would be highly associated with increased risk of mortality and or more severe COVID-19 disease.
Okay. I think we could continue.
So when we had this patient admitted, we started them on medications, of course. So we started them on ascorbic acid, azithromycin, 500 IV daily for 5 total days. The patient was getting hydroxychloroquine. They were also started on prophylactic dose of Lovenox of 40 milligrams sub-Q daily. They were getting famotidine twice daily, some insulin aspart on sliding scale, methylprednisolone, so corticosteroids, 40 milligrams every 8 hours. Patient was also studied on PIP, Tazo, Vanc, and midazolam drip.
Okay, before we proceed, just remember this is early March. You know, there are some treatment here that is proven we no longer use per CDC guidelines. However, there's a question in our chat box from Dr. Llewellyn asking whether this is low blood pressure. I wonder if this is a low blood pressure for this patient. Dr. Hudson?
So I believe this is a low normal blood pressure for this patient. So maybe slightly depressed, but not worrisome at this point in time.
Have we started a line on this patient and some hemodynamic monitoring?
Yes, we have started those at this point.
Yes.
All right. We could proceed. There we go. And there's a little comment here that the Lovenox was given 40 milligram daily. So I guess we have changed that too recently based on our current knowledge.
Yes, and I think we'll talk about that later in the presentation.
Okay. All right.
So then this is our second patient case, and this is from August 2020. So essentially what we would more define as a more current patient case. So we had a 48-year-old female transferred from an outside facility. The patient had several family members that were positive for COVID-19. She was complaining 4 or 5 days of shortness of breath with a dry cough and some subjective fevers, denied any chest pain, diarrhea, nausea, and vomiting, and is also noted to be altered. The rest of her review of systems was negative though. Of past medical history, just positive for hypertension, for which she takes lisinopril at home. And again, hypertension is potentially one of those risk factors for a more negative outcome.
Yeah, and the other thing to note here is the age difference. So we had a significantly elderly patient in upper 70s initially. And I would say that's consistent just anecdotally with what I saw and took care of in terms of our unit, primarily elderly patients, whereas as the pandemic has progressed, we're seeing younger and younger patients become affected with severe disease.
So of note, vitals on admission, she was afebrile. She was sitting at 91% on a non-rebreather. Her blood pressure was a little soft at 84/52, but that blood pressure did improve with some IV fluids. Labs on admission, she did have an elevated white count, and she did have some AKI, so her serum creatinine was at 2.2. We got a lactate, it was 2.1. Troponins were slightly elevated. Procal was slightly elevated, and then we also had an ABG that's listed for you there. In her EKG, she was in normal sinus rhythm at the time, and of note, she was positive for COVID-19.
The other thing, though, that's going on, or we're using recently in patient earlier on, is to evaluate their heart. Do some echocardiography of the heart to rule out any early heart injury. Have we done this in our patients or in your institution, Dr. Hudson?
That was not done yet in this patient. However, in my current clinical practice, we are doing some echoes, especially when we're seeing kind of a heart failure type picture in patients. But we're not routinely doing them on all patients that are admitted with COVID.
Any question from the group? Go ahead, Dr. Hudson.
So on admission, the patient was then transitioned to heated high flow oxygen. So a step up in oxygenation from a non-rebreather mask, because now we're to high flow. We're increasing our flow rates. And here's our vitals again. So still afebrile, except now we're sitting in the low 90s on heated high flow at 30 liters.
Dr. Whitworth, I noticed also there's a little change in paradigm of practice. Before, early intubation is the rule in COVID patient. Now we're tending not to intubate them sooner. Is that the case that happened here?
Correct. Yes, that's exactly the point, Dr. Santos. And initially, the thought was, let's intubate prone patient. Even, and we can talk about this later on as well, but paralyzed patient versus now the kind of rule of thumb is let's hold off on intubation as long as we can. This patient, obviously, given the information we've provided to you, this patient's progressing towards intubation, but we're trying to hold that off as long as we can with increased flow rates with humidified heated oxygen to support respiratory function and decrease tachypnea as much as we can prior to intubation.
And the key term you mentioned already is proning, and a big proponent of proning, and there's many ways of doing the proning, so probably you'll talk about that later.
Yes.
Good.
So this is hospital day one. Our vitals very similar, except now we're ventilated and with an FiO2 of 60. Our labs are as follows. Everything looks decently normal. Our AKI has now improved. Our liver function is normal of note. So AST and ALT are normal. We also got a ferritin. Our CRP is markedly elevated. D-dimer elevated also. Procal has started to trend back to normal, and our troponin has started to normalize also. So this is our patient labs over 14 days. So all of these are graphs of our inflammatory markers. So over on the left at the top is our CRP. Below that is our FiO2 requirements. Over on the right, our very top is a graph of our D-dimers. Below that is our ferritin, and below that is our procalcitonin levels. And at the very bottom of each side, we've kind of overlaid when the patient was receiving what. So initially, the patient got 5 days of remdesivir. Below that, they were getting initially high dose dexamethasone, which was then de-escalated to a lower dose of dexamethasone. And throughout the entire course of treatment, the patient was receiving antibiotics for community-acquired pneumonia. So as you can see, all of our inflammatory markers are actually aligning. And so initially we had a marked elevation in our CRP especially, but our other inflammatory markers were not as elevated. And with remdesivir and the high dose dexamethasone, those kind of normalized. And then towards the middle to end, we're seeing a spike in all of our inflammatory markers.
Dr. Hudson, what is our criteria before starting remdesivir? Because we all know this is experimental, well, it's approved now by FDA, but do we have any criteria when to start it?
Yeah, so we'll get to it in a little while, but initially the criteria it was initially just in severe patients. So these were more ventilated patients. And then the criteria was relaxed a little bit. And then the criteria was more patients requiring supplemental oxygen were receiving it. And then now that indication has been expanded to all hospitalized patients.
Yeah.
Dr. Llewellyn had a question. Any PCO2 levels?
I didn't capture those, and I don't remember off the top of my head what those were. I'm sorry. I don't want to speak because I'm not sure. I didn't capture those, but that's a good point. If you're curious, I can capture those and send them out to Dr. Santos to share with the group. The other thing I was going to point out is that, as we mentioned before, in the ICU, we're monitoring most of these values daily, as we said, and you can kind of witness that here with the circles would be considered each day. You note that the procalcitonin, so the very top or the very bottom right graph, we stopped checking for a period of days because it was essentially zero. And that's pretty consistent in what we're doing in practice, I would say, in my institution, trying to just hold off on blood draws if needed or excess labs if needed. But you can see that as soon as we saw some spike in our inflammatory markers, we rechecked procalcitonin just from as a rule out option to make sure that we weren't developing any other secondary bacterial type infections. The other thing to note is that the day of or the time period related to the increase in these inflammatory markers. And so this is pretty consistent with what we're seeing in the community as well as in the hospital, in that that 10 to 14 day period often is some of the most worrisome in terms of where we see patients either decline significantly or require additional support from an oxygenation and ventilation standpoint. So even those first 10 days, and just personally experiencing this from family members and loved ones, is those first 10 days can be somewhat stable, but then you're really not quite out of the woods yet once you hit that 10-day mark. Usually the 10 to 14 day period is a trial period to determine overall mortality and prognosis, because patients can suddenly worsen quickly in that period of time, which is exactly what we see here.
So overall, just a brief review of our summary of things, major points to watch for. Some major decision points that we're making throughout the course of treatment in patients with COVID is we're closely monitoring their work of breathing and hypoxia. So that's a great driver of, number one, their treatment in addition to their prognosis and their respiratory requirements. So there's several ventilation strategies, from heated high flow nasal cannula to regular nasal cannula to venti mask to a non-rebreather mask, all the way to mechanical ventilation. We've noticed that inflammatory markers do correlate with disease severity. Occasionally we'll see an excessive immune reaction that may lead to a cytokine storm type picture. And then our early treatment recommendations were based on indirect evidence, which we'll discuss going forward.
Any other facilitation or question points, Dr. Santos? I can't view the chat before we move into the didactic portion.
Yes. I don't think there's anything new in the chat box.
Nothing.
Okay, so let's proceed, Dr. Whitworth.
Sure. Okay, so in keeping in line with our objectives, let's first talk about remdesivir. This is what we would consider a broad spectrum antiviral agent. It's specifically a nucleotide analog, and so its purpose is to inhibit the virus's ability to synthesize from an RNA standpoint. It was provided an emergency use authorization by the FDA on the first day of May in 2020. And so that provided some specific criteria for utilization. Dr. Hudson mentioned initially was targeted just primarily due to supply concerns, was targeted towards more severe patients because the thought was that if we can lessen the burden related to that cytokine storm, lessen overall viral load in those severe patients, that we can improve prognosis. Since then, we have much more data available to us since May. And so last week, even on October 22nd, the FDA actually approved the very first agent, remdesivir, for COVID-19 treatment. And so this was specified to be used in any hospitalized patient with COVID-19. The recommended dose and duration is a 200 milligram IV loading dose on day 1, and then 100 milligrams IV daily thereafter for a total of 5 days. And so the guidelines align pretty well with the most recent data, along with the FDA approval of use for this agent in patients who are hospitalized requiring supplemental oxygen. And the actual recommendation is in patients who are considered not to be having severe COVID-19 disease. So those without requiring high flow nasal cannula, mechanical ventilation, whether that be invasive versus non-invasive, or ECMO. And so this is defined as an ordinal scale of 5. And so just to summarize what that means, if you're not familiar, most of the antiviral or SARS-CoV-2 specific therapies most of those trials are utilizing a ordinal scale to define disease severity. And so I've just put that on the screen here for you just as reference if you're not familiar with it. 1 being not hospitalized, no limitations, all the way to 7 being hospitalized and receiving invasive mechanical ventilation or ECMO. And so specifically for remdesivir, we're looking at those patients in the 5, 6, and 7 ordinal scale categories. So those that are hospitalized and receiving oxygenation via supplemental support. But the preference really in the guidelines specifically is really tied to this number 5 category. So those patients who are receiving supplemental oxygen but haven't met criteria for severe disease. So that's summarized here on this slide in terms of the evidence that's available regarding remdesivir's use and indication in COVID-19 disease. And so there are 3 primary studies that have become available to us that have really guided these recommendations. And so just to kind of go over those so you understand a little bit of the background of why. The first was conducted by Wang and colleagues, and this was remdesivir for a total of 10 days that was compared to placebo. And this was primarily including patients that were in that, I would call that ordinal scale of 5 category, so moderate to severe COVID-19 disease. And we see that overall that their primary endpoint was time to clinical improvement. So did we reduce the length of disease severity essentially in this patient population? And we see that this was an improvement, but not statistically significant. So the hazard ratio of 1.2 there. And then the 28-day mortality was really no different between the 2 groups. So not a strong case for remdesivir initially. The ACT-1 trial was the most recently final publication that was published, I believe, a week, maybe 2 weeks ago. The final results were available to us. We've had preliminary results for the past month or so, if I recall. But this was remdesivir for a total of 10 days versus placebo. And again, those patients that were included were in that ordinal scale of 5, 6, and 7. So they included severe patients on ventilation, requiring ventilation support, but also included patients just hospitalized requiring oxygen. And you see that their overall time to recovery was reduced significantly in the remdesivir group. The 28-day mortality was not significant, but trending towards an improvement. with remdesivir. And then the Simple 1 trial series, there are a couple different trials available in terms of evaluation of remdesivir. The Simple 1 Severe is specifically evaluating critical care patients, so those in the ICU receiving supplemental oxygen, so that ordinal scale 5, 6, and 7, but primarily a severe disease. And so their primary outcome was evaluating clinical improvement on that ordinal scale, but they were evaluating two separate groups in terms of duration. So not just the drug itself, but remdesivir 5 days versus remdesivir 10 days. And we see that 5 days was as effective or more effective than a 10-day course for remdesivir. And so this is where we get our overall final recommendations for utilization of remdesivir in these patient population groups that are hospitalized with supplemental oxygen on that ordinal scale of 5, 6, or 7. But primarily, the biggest benefit was seen in all 3 of these trials. The biggest benefit was seen in those patients in that ordinal 5 scale. So those that were receiving supplemental oxygen, but not yet ventilated, not yet intubated and receiving invasive mechanical ventilation. The pathophysiology behind that is that we are preventing cytokine storm with remdesivir due to decrease in viral load. So rather than focusing all of our efforts in terms of treating those patients with a severely low prognosis already with severe COVID-19 disease, we're focusing our remdesivir efforts on those patients who have not yet met criteria for severe disease. So it's a huge shift, I think, in thought process in terms of management than what we initially thought of when the drug first came out in April, May. So overall clinical pearls to consider when using this drug is, we talked a lot about in our cases, the specific liver and kidney function parameters that we would monitor. Specifically, the FDA recommendation and the studies themselves excluded patients with an eGFR of less than 30 or specifically an ALT, but I think you could extrapolate that to AST of greater than 5 times the upper limit of normal. And so this is primarily what we're doing in our hospital. And I know I'm aware of several other institutions that are holding to these criteria initially. One thought when evaluating these specific trials is most of the outcomes were time to or evidence of clinical improvement using that ordinal scale. And so one thought that has been proposed is, are these clinically significant outcomes? Are we truly seeing a difference in disease progression by using that ordinal scale as our overall outcome, or is there a more meaningful marker that we should be evaluating? We talked about the 5 versus 10-day duration in severe illness. Specifically, this was not specifically studied in that Simple 1 Severe trial, although we see that 5 days was no worse than or better, potentially better than the 10-day duration. This doesn't always extrapolate to severe illness. And so a small portion of those patients actually did improve with an extended duration. And so the guidelines do recommend consideration for extended duration of remdesivir based on provider preference in severe illness, which would be considered our ICU patients.
So what are we using right now, Dr. Whitworth? Sorry, what are we using right now? Are you using the 5-day course, or if the patient is still severe, did we extend that? So
yeah, in my current practice, we're using 5 days. Very rarely do we extend to 10 days. Initially, I would say May and June, we were extending to 10 days based on critical evaluation of patient symptoms and overall prognosis. But I think in the last couple months, we've seen with these new data that have come out that the 5-day duration, we're pretty much sticking to it. Now, is that the right thing to do? Based on the data, it's hard to say, because I talked about the previous 2 trials, specifically the ACT-1 trial, which was highly powered. It was an excellent study from a statistical standpoint. They evaluated 10 days. And so whether or not 5 versus 10, it's a little bit hard to answer at this point. But the Simple One severe trial showed that 5 days was essentially no different. The typical 5-day course for remdesivir in terms of cost is about $3,000 roughly. That's just from my one institution, so it may be different depending on where you are. And then other things to think about as we move into the winter season is we've already had discussions at my institution in regards to this is how many doses we have left and how are we going to extrapolate those to ensure stewardship to our patient population. And so I think these are some questions that have been proposed in terms of making decisions as to who would get remdesivir if we have 5 doses left and or five courses left and we have 6 patients, who's going to get them. And so one is, do we consider that category 5 on the ordinal scale as a initial recommendation that those patients should absolutely receive it? Do we consider withholding all courses to just 5 days? We mark at 5 days and that's all the patients are able to receive. There's been some other evidence or discussion in the literature that I've seen related to rechecking a SARS-CoV-2 PCR and following those. Now that can be a little bit tricky with our testing woes that we have, but potentially considering the days that they've been positive and following PCRs from there have been come up. I would love to hear if anyone else has any other thoughts on how to consider this. I'm afraid that we will be in this situation sooner rather than later, given our current hospital status.
All right. Any other questions from the group? Go ahead, Dr. Whitworth.
Yeah. I'll keep moving along, and if you have questions or thoughts, throw them in the chat, and we can discuss them. So the second point is to discuss steroids, and I just threw out a question here to consider as you listen to the next few slides is, in which hospitalized patient group do you recommend the use of corticosteroids, all the way from invasive mechanical ventilation to room air, or all of the above? Or if you're unsure or undecided. If you have an opinion on that, please throw it in the chat using just A, B, C, D, E, or F. I'll give you just a minute to do that. And so while you think about that, I think the primary discussion related to use of corticosteroids in COVID-19 disease is that it's an immune modulator. And so again, we are trying to reduce or prevent that cytokine storm phase, otherwise depicted in this diagram as that hyperinflammation phase, that stage 2, where our host cells immune response actually is exceeded in response to the toxins from the specific virus. And so you can see some of the signs that we've talked about already in our cases is that these patients have lymphopenia, usually on presentation, and that lymphopenia generally worsens as patients progress through these stages. We also see hypoxia and shortness of breath progress in these stages all the way culminating in ARDS and or cardiac failure or shock. And these inflammatory markers that we're following specifically related to this host response, this host inflammatory response phase, are the CRP, the D-dimer, the ferritin. IL-6 was primarily targeted early on, I would say April, May, June, primarily related to some of the agents that were used or being studied in COVID-19. So we were monitoring IL-6 at our institution for a period of time. It was a send-out lab for us, and so it would take us approximately 72 hours to return those values back to us, which was unfortunate and really not clinically much use for us. But we did often check those. We aren't doing so much anymore because of the changes in the recommendations for the management, which I'll go into here shortly. So our primary inflammatory markers that we already mentioned discussing, CRP, D-dimer, and ferritin primarily. So the first trial to evaluate steroid use in COVID-19 is known as the recovery trial. This is just a 5-second review of what this trial evaluated. This was evaluating dexamethasone versus usual care. The primary recommendation for dose and duration was 6 milligrams daily for up to 10 days. And this was specifically in COVID-19 patients. They evaluated all types of categories of patients on that ordinal scale and showed that dexamethasone actually decreased 28-day mortality significantly, statistically and clinically significantly, primarily in patients who were mechanically ventilated, although the improvement was seen throughout the ordinal scales. But really the primary benefit was seen in mechanically ventilated patients. So those patients with ARDS type pictures. There was also significant secondary outcomes that were shown to reduce hospitalization, discharge days, as well as decreased risk of progression to vent. So this is the first actual therapy that was shown to reduce mortality in COVID-19, and this is known as the recovery trial. In comparison, just on the cusp of COVID-19 pandemic, so in November, December of 2019, a trial was completed known as the DEX-ARDS study. This was non-COVID patients, obviously, because we hadn't yet moved into the pandemic, but you see the duration and dosing listed at the bottom. So this was a much higher dose than was studied in the recovery trial. So this was primarily in ARDS patients, secondary to pneumonia, primarily not non-COVID pneumonia, but a much higher dose for, and then a tapering recommendation. So starting at a 20 milligram dose of dexamethasone and then decreasing to 10. And you can see similar reduction in all-cause mortality was seen in this study as compared to the recovery trial. And so just an overview of that would be the dosing specific recommendations are different between the DEX-ARDS versus the recovery trial. Only one of those included COVID-19 patients, so that's something to consider. The actual choice of steroid was significant in that dexamethasone was chosen for a purpose. You know, we often use other types of steroids in that are recommended in shock versus adrenal insufficiency, secondary to sepsis, or et cetera. But dexamethasone specifically is chosen in this patient population, ARDS, secondary to COVID, due to its longer half-life, its less mineralocorticoid effect, and so it's decreased in its ability to retain sodium and therefore water. And so because a good portion of ARDS management is keeping the patient's fluid balance negative and or dry at all possible. And but when we try to extrapolate this to our COVID-19 patients, we have run into at my specific institution some availability concerns with dexamethasone. And so we are using other corticosteroids. I think that can translate in terms of an equivalent dosing structure, but know that dexamethasone was specifically chosen for this reason. Duration is still a question. Is 10 days enough? Both trials evaluated up to 10 days, but the dosing was different. And so in my institution, we constantly have this discussion over whether we want to stop the steroids at 10 days or keep them going. You saw in our patient case number 2, we had stopped we had decreased the steroids after about 7 days, and inflammatory markers went up after that. And so is that a concern? Is that something we should be considering? And then obviously the complications associated with steroid, and including hyperglycemia and co-infections as well. So the actual guidelines recommend for COVID-19 disease in all hospitalized patients receiving supplemental oxygen, dexamethasone 6 milligrams daily for 10 days based on the recovery trial. And then one point just about co-infection and COVID-19 disease related to antibacterial agents. in addition to COVID-19 specific antiviral therapies, you see overall co-infection is low, secondary infection after presentation is higher, but our overall prescribing of antibiotics is significantly high. So this was early on COVID, so through March, but I think it still translates to our current practice. And so considerations for always on a day-to-day basis, to continue antibiotics, can we de-escalate at this point? Should we discontinue all antibiotics? And what clinical parameters are we evaluating based off of that? And then my last discussion is going to be based on anticoagulation. So specifically in COVID-19, we know that it results in a hypercoagulable state that's not traditionally similar to DIC. We do see an increase in thrombosis related to COVID-19 disease, even with VTE prophylaxis. And so if we're not giving VTE prophylaxis, which we do anyways in all of our critical care patients, then what should we do? And so those guidelines actually differ significantly in terms of recommendations based on organization that you look at. There's not a lot of great quality data to support these recommendations, but primarily we're considering standard prophylaxis in all hospitalized patients with COVID-19 disease, but is there some consideration for increasing that or titrating up that prophylaxis in dose or duration is a consideration. So some of the things that we're evaluating are D-dimer. Specifically, I mentioned that 2 to 3, primarily greater than or equal to 3, D-dimer is associated with increased risk of thrombosis and poor outcomes. And so at my institution, we're monitoring D-dimer and making decisions for anticoagulation based off of that. In addition to the severity of their disease, there's been some evidence to support the SIC score, the SIC score, or using SOFA score has also been evaluated to determine if greater than a certain threshold to consider escalating the dose of anticoagulation. I provided some examples for what that escalation would look like. And also there's some consideration in terms of extending the duration of prophylaxis. So even after patients discharged, extending that duration. We currently aren't doing that on a consistent basis at my hospital, but there are some institutions that are advocating for that in certain patients. And then just the last piece here is supportive care related to COVID-19 disease. So we're primarily monitoring sedation and ventilator dysynchrony. And so if dysynchrony is present, we generally tackle that first with analgesia and sedation. And so analgesia first always, so primarily using our opioids, and then sedation agents as well. We're primarily seeing higher doses being required in these ARDS COVID patients than we even generally see in our non-COVID ARDS. And so monitoring toxicities related to those drugs is important. I mentioned neuromuscular blockers and utilizing those primarily in our patients who we are proning. And so on ventilator, and so making sure that they are tolerating and synchronizing with vent while proning. We can use neuromuscular blockers, generally seeing longer durations and higher doses than I've ever seen before in ARDS. And then other adjunctive agents, I've used more ketamine than I ever have in my entire career. And so any utilization of adjunctive agents to try and minimize the toxicities that we see with our other analgesia and sedation agents as well. Glycemic. Yes, go ahead.
That is a wonderful presentation regarding updates on, COVID-19. But unfortunately, due to time constraint, I will have to flip the presentation to Dr. Armeniak. And
yes, thank you. I'm sorry about that.
And if you have any questions, kindly please email me or Dr. Whitworth for any questions or clarification. Anyway, for our next talk, Dr. Armeniak is a director of the Center for Advanced Analytics and recently served as Director of Best Practices Telecritical Care in Baptist Health, South Florida. She is currently served as SCCM Chair on Research Section and Chair of the Telecritical Care Committee. So another person from SCCM here. She's also had a designated seat in Discover Research Network Steering and Oversight Committee. Donna draws from her critical care clinical experience to evaluate factors that influence clinical outcomes, quality healthcare, and healthcare delivery. So I'll give the floor to Dr. Donna Lee Armaniak.
Thank you, Dr. Santos. I'm very honored that you invited me to speak to your audience. I had not known about Project ECHO previously, so I had the fortune of learning all about that, and it's directly in line with many of the initiatives that we're working on locally and nationally and internationally. So I come from a nice little place, Miami, South Florida. Okay, my slide's moving. Here we go. Okay, I have no disclosures. Okay, now we all know what's been going on for the past 280 days, and we all know that we're going into our third spike, anticipated to grow. Okay, this here is a map of our country, and you can see that the darker areas are currently experiencing more cases. I bring this to your attention regarding certain counties, and in Florida we have Broward County and Miami-Dade County, which are among the top 10, and also Miami-Dade is among the top 10 as it relates to deaths. I believe that you folks you had a really difficult time maybe a month or two ago in Texas. I don't know if you're still in that same situation, but now we know that the upper Midwest is having a terrible time. Okay, this is the map, the Johns Hopkins map. I don't know, probably most of you are familiar with this. I stop on this because we talk about case fatality. Case fatality is 2%, 2.6% in the States and 2.6%, believe it or not, globally, except this is fatality for all patients that became positive. It's not for hospitalized patients. So I'll be interested to see how our hospitalized patients fare. Now, for more than half of a century, counties do not have any intensive care unit beds to care for these critically ill patients. Among ICUs that do exist, only about a quarter of them are staffed with critical care trained intensivists, despite evidence showing that intensivists improve mortality for critically ill patients, which is a little bit controversial in the literature right now. One reason for this mismatch is that many smaller hospitals do not have enough critically ill patients to warrant hiring specialists, and hence rely on transferring these patients who have life-threatening illnesses. And I think that's where your Project ECHO has been instrumental. While that system does have its downsides, because we have taken patients away from their local area, but in a disaster or pandemic scenario where patients need critical care in huge and sudden volumes, this poor geographic distribution of specialized expertise can become acutely problematic. Okay, so for decades, health systems have been pioneering the use of telehealth to extend capacity. Evidence shows that these services are quite effective. However, the ability to scale is a challenging element. Telecritical care also faces policy barriers, as this audience I'm sure very well knows. Okay, but COVID-19 has been it's been a year. It's been a year we're all going to remember and reflect upon. It has demonstrated an impact of large-scale health emergency on our existing infrastructures. We've known about this since Ebola and 9/11, and we've been evolving. And due to the challenges and pressing priorities, the idea has struggled to gain traction, i.e. having a national response. Okay, so coronavirus has led to this national crisis, as you know. Two gentlemen here, we have Colonel Pamplin and Ben Scott. So the Society of Critical Care Medicine Telecritical Care Committee and Telemedicine Advanced Technology Research Center got together, and we were setting forth on preparing, telecritical care disaster response, and we were just getting going, and lo and behold, COVID came to town. So we went through a rapid ramping up stage. Okay, this right here, National Emergency Telecritical Care Network, otherwise known as NETSIN, is a cloud-based, low-resource, standalone health information management for the creation and coordination of flexible and extendable virtual critical care. This is just a graphical depiction. Due to time, I'm going to move a little bit quickly over things. I encourage you to visit NPR healthcare policy investigator Dan Gorenstein, his show called Trade-Offs. It just went live. It is an interview with military and FCCM regarding the NETSIN program. I'm going to now shift over to a bit of research. Now, telecritical care as a specialty is now quite well established and highly functional. The research has yielded evidence of positive impact and helped institutions to provide high quality care, provided many affordances. However, many of these studies, there exists great variation in who, how, and where these services have been applied. Okay, so the optimal model is unknown. The SCCM Telecritical Committee did a systematic review, and they identified certain areas that are in need of further analyses. We've all been hearing about the shortage of intensivists for a while now, another thing that's a little bit controversial in literature. So we set forth to determine if there's a difference in ICU and hospital patient care outcomes with telecritical care delivery models with and without exposure to bedside intensivists. And I'm trying to keep mindful of my time. I'm not sure how much I'll be able to go over with you guys, but I'll just tell you that this was a natural experiment, quasi-experimental design. We have 12 ICUs across a large hospital system covering, mid to South Florida, 20,000 patients. Standard of care in our organization, everyone has 24/7 tele-intensivist, and model A, we call it, has the bedside intensivist, and model B does not have the bedside intensivist. Okay, so the sample, the population was unbalanced with respect to volume and severity. However, we applied some indirect and direct standardization techniques. And our SMR was, every SMR in all of our sites was not significantly different from one. However, for the critically ill patients, we did see a significant difference between Model A and Model B on all of our key metrics. We conducted internal validity testing on Apache, so it performed equally well for everybody. We did some advanced analytical modeling, GLM, and this takes into anything you could ever consider into the modeling: hospital characteristics, patient characteristics, and all of our indicators of interest were all significantly higher, worse in Model A than Model B, including cost. All right, and we also did something called a GEE modeling, and this was testing if there's any interaction between the models and the risk strata, and there wasn't. What this does is implies that exposure to bedside intensivists did not differ significantly between risk of mortality and percentile groups. And that also brings you to the conclusion that the only thing that could be potentially influencing this is the actual exposure. Okay, sensitivity analyses. This is one I really was very surprised about. A priori, we identified patients, specific subpopulations that we believe with the highest critical care needs, we believe that would, benefit most from the bedside intensivist. Once again, with very advanced modeling, that wasn't the case. So, and this applied to patients in the ICU less than 24 hours, nighttime admission, mechanical ventilation, sepsis, highest physiology scores. I mean, all the different things that we would anticipate bedside intensivist, and it wasn't in fact the case. So, of course, every study limitations and strengths. Despite all of the limitations of doing an observational design, these advanced analytical models controlled for everything in every which way, and all the evidence was consistent. We do know workflow. We have workflow differences. There's other untested hypotheses, but we believe that this provides evidence that we can say telecritical care is not an alternative, an adjunct, or a replacement. It's a specialty practice of its own with generalizable, significant effect on care under routine standards of care. And cost is another area we're going to be going into more in depth. And we still recognize that the optimal model is not clearly, at our grasp. This is a new area of research, but it is original research that is showing some interesting things. It's under review right now. And I'm sorry I had to run through things, but I do appreciate your attention. It was my honor to speak to this audience. Thank you.
Thank you very much, Dr. Armaniak, for the wonderful presentation. I apologize for the time constraint, but you showed wonderfully how tele-ICU, while telecritical care networking is vital, especially in this era of pandemic. The other thing, though, is you don't need to, doff and don and use PPEs while you are, across a console, right? So what do you think is the future of the telecritical care network?
The National Emergency Telecritical Care Network just got $45 million from HRSA over the next 4 years. So we're going to be stress testing it and working it all out and addressing all of the challenges. And it's in Guam, it's in Oklahoma and South Dakota. They had different contender groups that were, in competition to, do this most effectively. We believe it's going to be quite effective, and down the road, if it evolves to the ability to transmit live data, we think it'll be even more fabulous. And the other thing that our work is telling us is you don't need disasters, you don't need anything. Telecritical care is a standard of care on its own.
I completely agree with you, Donna. And the other thing, though, is here in Texas Panhandle area, we have a lot of areas wherein there are critically accessed hospital.
Yep.
Rather than sending it over here, we
Yes.
offer capacities to stay there, and I think
Exactly.
really will be glad to just stay there rather than travel 3 hours from Lubbock.
Yes.
Amarillo,
Yes.
for that matter.
Yes. The only thing we need a physical person for is lines and maybe a chest tube.
I agree. Well, thank you very much, Dr. Armaniak, for a wonderful presentation. If you have any questions, you feel free to email Dr. Armaniak about this. By the way, I would like to remind everyone to fill up their session evaluation for your CME units. And we have a QR code as well that you could use. And also mark your calendar on November 19, 2020. Dr. Edwards, who is also here in this presentation, will be presenting diagnosis, prevention, and treatment of COVID-19 in school campuses, which is very apropos during this time period. Don't forget to complete your evaluation, and you could use the QR code here as well. Any other questions from the group?
I just want to make a call out. If anybody's interested in pooling their data and doing research, let me know. We're trying to, get lots of research networks together.
Thank you very much. Dr. Kathleen To from University of Maryland is here with us as well. She's part of SCCM Patient Safety Chair of the surgery section. So glad we have a lot of wonderful people here.
Okay, thank you.
Thank you very much for joining us, and sorry for the overtime, but join us next November 19th.
19th.
Yes, 1 p.m. and stay positive and test negative, guys.
Thank you.
Thank you.